The content herein is for informational purposes only, not intended as medical advice, diagnosis, or treatment, and is not to be substituted for direct advice from your doctor.
Today's LymphCast program is proudly sponsored by VitaSupport MD, the makers of Vein Formula 1000 and Lymphatic Formula 1000. These MPFF-based nutraceuticals are backed by science and recommended by doctors specializing in venous and lymphatic disorders. Visit VitaSupportMD.com to learn more.
Welcome to LymphCast, the show that brings together doctors, other health professionals, and special guests to discuss lymphedema, venous disease, and other associated disorders, and what can be done if this is affecting your life. Now it's time to sit back, relax, as it's time to learn all about lymphedema, venous disease, and associated disorders on our show, LymphCast.
Welcome, everybody, to the LymphCast, episode 22. I'm Dr. John Chuback, co-creator of the LymphCast with my amazing team. I'm filling in for Dr. Paul Reeves today and will act as host and panelist. So I hope I can fill Paul's big shoes. He's led us this far, and hopefully he's given us some good examples about how to conduct a good interview and a good discussion. Let me begin by welcoming my dear friend and colleague from Minnesota, Dr. Mark Melin. Mark?
Thank you, John. It's a privilege to be here today, and I'm so looking forward to spending time with our guest that Dr. Gloviczki has invited.
Thank you. And from beautiful Santa Monica, California, the preeminent and excellent clinician and physician, Emily Iker. Dr. Iker, welcome.
Dr. Chuback and team, thank you so very much for including me into this fantastic team and welcoming Dr. Lohr to tell us more about her clinical experience. And by the way, California is not sunny for the past 2-3 weeks. We have rain and slides, mudslides, and everything else.
Well, we wish you the best there. Hope everyone is safe, and hopefully it will result in some beautiful floral blooms. A little rain for Southern California is probably a welcome treat in some ways. Dr. Gloviczki, welcome as always. Last but not least, Monika Gloviczki, joining us from Arizona. She has a little bit of cloudy skies there today, apparently, too. Monika, welcome.
Thank you very much, John. And hello to everybody. Hello to my team, and hello to my guest, who is also a very good friend of mine. And I'm very happy that Dr. Lohr accepted our invitation for today's LymphCast.
Yes, very much so. Couldn't agree more. And speaking of which, Monika, if you would be so kind as to introduce today's guest.
Yes. So I will be very brief because I want most of the time to hear Dr. Lohr, Joann, to talk about her experiences with lymphedema. But to tell everybody, Dr. Joann Lohr is a vascular surgeon, actually working in Columbia, South Carolina. She is an eminent expert in venous and lymphatic disorders. She is a member and distinguished member of the American Venous Forum, and she is the first female president of the American Venous Forum. And just recently, we had the pleasure to see Dr. Lohr awarded by the AVF Founders Award, which is a very distinguished award that we have within the venous and lymphatic community.
Thank you, Dr. Gloviczki, Monika, my dear friend, and everybody from the LymphCast team for having me. I have prepared a series of my friends from practice. I spent my vascular fellowship in Cincinnati, Ohio with Jack Cranley, And that's where my interest in venous disease and vascular imaging began in the late 1980s. So I'm going to go ahead and try to see if I can get this screen share to work, and we'll have some pictures. And please feel free to interrupt. And this is hopefully a conversation. I'm going to focus this morning on my friends that presented at a young age and have perhaps some unusual management challenges, and focusing primarily on lymphedema precox, but we've got a few other things to talk about as well. So again, thank you to the LymphCast team and to Dr. Gloviczki for that lovely introduction. I hate to show you this slide, but this is my yard last week, and it's sunny and beautiful here again today. So it will be spring soon everywhere else. So we're going to focus on our lymphedema precox, which is the most common type of primary lymphedema. There's congenital, which involves the patients that are less than a year or two old, and then there's the tartar that happens after age 30. But this is a series of friends that I have in practice that presented between age 11 and 25. And most part, they were sent in because nobody could figure out why they had swollen toes, and they didn't have an orthopedic problem. They'd been worked up for all kinds of other things, and nobody could really figure out what was going on. They'd had no injury. They didn't have any underlying venous disorders or anything else they could find. And this is a typical patient. You can see she's got some squared off toes on one side, just very mild changes and subtle. And as you look at her, it's a little bit hard to tell. She's got a little sunburn, but when you really look at her toes, they show you that she's been having trouble for a while. Her biggest complaints in this initial phase and before it's totally evident were that she had some heaviness and aching, some tingling, some tightness, that she really didn't have any swelling. She noticed she just kind of had these fat toes, and this had been going on for quite a while. This is much easier to recognize and has the classic buffalo hump, and is a more advanced disease, obviously not one of my precox patients. Again, they all love the nail polish. I'm sorry for the nail polish because some of it's quite distracting, but here again, you can see the buffalo hump and a lot of the skin changes that occur later in lymphedema. But these young women come in and they've been seen by multiple people, and they really have not been given a diagnosis. And you can compare these toes and you see the difference. You can start to see the web spaces are filling in and the toes are starting to change.
So I have a question. I have a question for you, Joann.
Yeah.
So how those patients, especially for the young girls, are finding the way to you, because these are very discrete changes still. So how is that you get the chance to see them?
Well, unfortunately for them, most of them have seen orthopedics, podiatry, sports medicine, and their family doctors multiple times. And I'm kind of, the joke was that I was sort of like Dr. House. If they couldn't figure it out, send it to Joann and she would come up with some rare diagnosis. But as you can see, I accumulated quite a crowd and had a whole group of young teenage women. And so in the practice, we started to network. And so once you make friends with a few people, the word spread among the patients and the primary care team. So more than anything, it's about trying to get the most accurate diagnosis and preventing problems as you go forward. And, you like to get everybody where they're stage 1 and they just have some of these subtle minor changes and prevent them from having more and worsening issues. Now, teenagers, like everybody, and most of you have had children, I think, probably, or have them. They want to fit in. They want to be like everybody else. They don't want to stand out. So putting somebody in a compression garment is not always easy, and convincing them to comply is even more difficult. A lot of times we get buy-in from their parents, but the patients themselves were sometimes a bit difficult. One of the things we established in the office, we established a network where my older lymphedema patients established, probably fast forward 10 years beyond these teenagers, the ones that had pregnancies and were further into their 30s, agreed to be mentors or contacts for some of my young patients. And so we would establish a networking group. And so with the patient's permission, we would give a contact number to the newly diagnosed patient and say, here's a person that you can talk to who's been through it and may be able to help you, be a sounding board. And so that was one of the things that I think probably expanded my network and exposure to some of these early young women. So again, you can just kind of, you see the subtle changes here.
Yeah.
Now we're getting a little less subtle. This one, has gone on to more like stage 2, and she's starting to lose the shape. She's getting more fibrotic changes and a more abnormal protein-rich fluid building up. Some of these are less obvious, and it was a challenge to get the primary care people to always understand what they were seeing. But the vast majority of the patients came from primary care. And again, you want to see them before they look like this, and you want to keep and prevent them from looking like this. You want to improve their skin care and their foot and nail care, and stress to them the need to avoid any infections.
Joan,
So again,
Yes, Mark,
go ahead.
do you want
can
to-
I ask one question? Because it's something I've always struggled with, and that I think a lot of my colleagues struggle with, is when we talk about genetics, we always expect it to be symmetric. And you've really shown some great pictures of the asymmetry of genetic lymphedema. And what are some of the thoughts about why there may be one foot involved and not the other foot involved, even though it's a genetic component?
Most of the ones I see or saw early on were usually unilateral. Most of these young women were unilateral. I had very few that had bilateral disease. That being said, I'll show you one at the end that's really striking. Again, nobody really knows. There's a speculation about the estrogen, but again, you would expect it to be in both legs. None of these children, none of these young women had family members with lymphedema. It was interesting. They seem to be more sporadic rather than the genetic or familial linked people with disease. I think the genetic linked and the familial stuff, it tends to be more bilateral than the sporadic.
And even in this picture, it's a gorgeous example of that asymmetry with just the significant difference between the toes. And it's such an important clinical finding for us to help educate our colleagues on in identifying this.
Well, we keep trying, and all you can do, I actually had a couple of young women that had upper extremity stuff too, but the photographs I couldn't find in my slide set, so I apologize for not including them. But again, it's a matter of trying to educate the public and educate the primary care team to even consider that this may be a primary lymphedema. Everybody's so tuned into secondary lymphedema that they overlook this. And almost all of these young women had not had a previous infection. So, they hadn't had a trigger other than their hormonal changes. So they've all, for the most part, had all the secondary causes ruled out and imaging done extensively, looking for congenital anomalies and outflow obstructions and venous issues and all the other things, but really didn't have anything else that they could come up with as far as an etiology. So, again, again, this is a nice picture because this young lady had a nice positive stemmer sign when you tried to pinch her, and so we got her settled down.
I'm stopping you, maybe for our audience, for our listener. You could explain what is the stemmer sign.
Stemmer sign is when you try to pinch the tissue here and you really have trouble pinching it. You don't have any trouble getting the skin to come up here. This has got a lot of fibrotic changes and fluid, protein-rich fluid that builds up and then results in some fibrosis and scarring. And so this tissue over time, and I'll show you some pictures at the end that are pretty dramatic about the woody induration and changes that occur as the skin damage is progressive. So And the whole mission, obviously, is to try to prevent any of those things from happening and to decrease the amount of fat, fibrosis, and skin overgrowth that we see. Biggest important thing is to decrease infection rates. And so we talk a lot about nail care. We talk a lot about skin care. We talk about that you shouldn't be shaving with a razor blade, that you need to use moisturizers daily, that you don't use harsh soaps, and we don't use manly soaps. We use Dove or a glycerin bar below the knee, and maybe don't even use soap except every other day below the knee because you don't want it dry. We want to avoid any cracks. And, this lady, you try to get rid of all of this dry skin around the calluses, the nail bed, the nail folds. You don't want any calluses on the bottom of their feet. And so we spend a lot of time talking about prevention of infection and talking about progression of disease that is worsened with episodes of infection. Some of them I will actually give if they've had recurrent infections, and that's not usually this group, but if they've had recurrent infections or cellulitis, I will give the patients a contract. And the contract is you have a prescription for antibiotics to keep at home when you get the prodrome, because most of these people that have cellulitis and recurrent infections, and that would be much more like this person, you want to prevent the infections from progressing to cellulitis and requiring admission to the hospital. When they get their prodrome, they immediately start on their antibiotics. And this usually is before they see the skin changes, usually 12 to 24 hours ahead of time, they'll have this prodrome. And it may be pain change in the area. It may be shaking chills in some of them. They all have their own, but each individual patient knows the prodrome when they're getting their cellulitis or their infection. And so they have a prescription, so they don't have to call. They don't have to wait for a call back or go to the pharmacy. They have one prescription with no refills that they keep at home when their prodrome starts. When that starts, then they call the office the next day, and we see them either that day or the next day and try to make sure that they aren't getting into a worse problem. And we've been able to avoid a lot of recurrent hospitalizations for these people by doing that. The contract is if you give your antibiotics to somebody else or take them for some other reason and you don't call and come see me, then we don't refill your prescription. And in all years of doing that, there's only been one patient that we had to say she couldn't have any more antibiotics. So the patients really do want to be taken care of. And so you empower them to be part of the treatment plan. And that's really critically important. So this again is the backyard, but this was actually last summer with my puppy. And I was just going to pause here for any other discussion points or questions.
Yeah, Dr. Lohr, I would ask, could you go back one slide, please? This patient to me appears to have phlebolymphedema. Do you have any comment there?
I do, and I think that's the correct diagnosis. And you can see the buffalo hump, you can see the venous stasis changes. And so this is, again, somebody I put in here just to show you some of the dermatologic changes these people get with chronic lymphedema. This, again, is bilateral, has been worked up and does not have venous outflow obstruction. As we're putting in more and more vein stents to help with phlebolymphedema patients and ulcer patients that recur. So no, I agree with you. So this basically is just to kind of make the point of some of the differences.
Yeah, good. I think that's good for some of our viewers who may not be that familiar. Could you also go back to one of your early slides? The young lady that you mentioned had a suntan. One of the very early slides.
So she actually has, there she goes. She's got a little sunburn. You can kind of see it here.
I see that. Okay. I do see that from her slippers or
yeah, from her flip-flops or whatever she was wearing.
Yeah, because I was going to ask you if there was some element of hyperemia in the affected foot there, and if you ever see that as one of the components.
I've seen that a lot as a trigger for worsening symptoms in both lymphatic and venous stasis changes. And if they get a sunburn, a bad sunburn, it can result in a really bad burn with desquamation and a secondary infection that results in the need for skin grafting. So I warn all of them not to be in the sun and to not, if they're going to be in the sun, they've got to use their sunscreen. But some people go to Florida and it washes off or they don't reapply. And I've had a few people come back with severe burns and had to basically debride their entire distal limb and graft them. And so it's really one of those important things that everybody understands, that this is viable skin, but it's threatened skin, and it has to be handled with care.
Yeah.
Other questions?
Yeah, yeah, sorry.
I was going to ask one more, Monika, if I may, for listeners and viewers and patients alike. I agree with Mark that these are, such beautiful photographs. And I think for all clinicians, it's so important to take photographs. And over a career, these photographs become so valuable for teaching and sharing and for future generations of physicians and clinicians and so forth. The one question I would have for you that you might like to address, the squaring of the toes, which is so pathognomonic for this disease. Do you have any comment on what we believe the anatomical basis for that squaring is, if any?
Well, I think my personal belief is that I think it's obstruction in the small digital vessels, and they just don't drain very well, so they build up extra fluid. Anybody else have other thoughts?
I can point out that there may be obstruction or partial obstruction at the level of ankle, and we can visualize that very good with the indocyanide green study now. And most of the patients that I sent for the study, they did have an obstruction or partial obstruction at the level of ankle, either on the medial or lateral, more on the medial side, so which would then lead to the square toe on a second square toe, and then the rest of the toes. Also, the primary lymphedema never occurs symmetrical. In lipedema, we have symmetrical swelling. Primary, if it's bilateral, one is more involved than the other. And in teenage girls, usually it starts like in a sports injury, I twisted my ankle. And so the swelling does not progresses, but does not improve with time. And that is clinical presentation of what we see on this beautiful picture.
Yeah.
And that, I was just going to say, that injury component makes me think of, we've all seen people that twist an ankle and all of a sudden they have this horrible inflammatory response called chronic reflex or reflex sympathetic dystrophy, or now called CRPS. And you almost wonder if there isn't a neurogenic component to it, especially if there's minor trauma that somehow contributes to the underlying pathophysiology. And
well, it's interesting because none of these young women that I'm showing you complained of pain. None of them had, with the time I saw them, any pain complaints, which is usually true with the acute reflex sympathetic dystrophy presentation. So.
One other thing that we struggle with in our wound clinic to get especially toe ulcerations healed is simply the toe wraps and management of the toe. So do you have any advice for us for how to improve management of specifically the digit edema and swelling?
One of the things that I do is I always have them use, when we wrap, we put spacers between the toes, because otherwise you tend to just squish them all together and tie them into a knot. So we put spacers, and it may just be something simple like a 4x4 opened up to wick the moisture out and to help keep it open so that they don't macerate, so they don't constrict, and so that they can have maximum drainage from each of the digits. And if you wrap them too tightly, you end up almost with a tourniquet effect right across this part of the foot, which then actually makes your toe problems worse.
If I may include what I use in our clinic is when the patient goes into a compression pump, I use also special sleeve that is customized for with Velcro closure for the better enhancement of the flow, lymph flow. And when the patient goes with the toes like that into the compression sleeve, I wrap the toes with Celona. Celona is very soft, compressive, almost like a cast-like material. And it's amazing that after half an hour of compression pump treatment, you see great improvement. Is it long-lasting? No, just like a pump treatment. No, it's not a long-lasting, and that is why we promote bandaging and other compression garments.
Yeah, I would just add one last thought, and then we'll allow Dr. Lohr to move on, because I'm sure she has many more amazing slides. Just goes to show how great this talk has been already to inspire so many beautiful discussion points. But one of my personal beliefs is that the squaring is also somehow related just simply to the anatomical configuration of the toe, that somehow the tip of the toe is more adherent in terms of the fascial attachment to the bony tip of the distal phalanx, and therefore you really don't get edema at the tip, whereas along the sort of barrel of the toe, if you will, circumferentially, that fascial adherence is not as great, and there's more soft tissue, which allows for expansion. And as everyone has pointed out, there's most likely some element of obstruction, but then of course an element of dependent edema as well. But those are, personal thoughts that I've had over the years. I can't really prove that in any way.
Oh, it's very possible.
With regard to the shape, yeah.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
Yeah, so there is, having done a lot of amputation on toes and digits, there is more investiture in this part of the toe with the connective tissue. Down here, there's not a lot, and so that would make some sense and make anatomic sense to what you see in the operating room.
That makes me feel good, because I've always just wondered, it's such as I said, pathognomonic, clinical sign. And one of the things we talk about, Dr. Lohr, very frequently on this show, especially for our young physicians and our medical students and so forth who are watching, is the importance of the old school, what we call old school medicine. And at the basis of that is a good history and a proper physical examination. And I still think with all of our amazing diagnostic tools, a good clinician and a good physician and surgeon should really have a great set of physical diagnosis tools in their intellectual and technical toolbox. So these images are just so powerful for me.
Well, and I hope, especially to the young physicians and trainees, that you remember this, because the patients and their families are always amazed when you could say, well, I could tell you what's wrong and how we're going to treat it. And then they go on the website and they come back with a whole printout and they think, wow, you were really smart because you told me all this when I was here the first time. And it starts to make some sense to them, but the web has helped as well. So.
Exactly right. Why don't you go ahead and proceed with the rest of your presentation, please?
Oh, all right. Well, I'm going to skip back here to the puppy. And he's my pause to start introducing a young 14-year-old that I got a call from the primary care doctor saying, I would like you to see this young lady. She has some blue bumps. She's not herself. She's got arm swelling, and there's something wrong. Maybe you can figure this out. So this is my friend Lauren, and you can see here she's got these blue shadows on her shoulder girdle here on this left side. And this was from 2012. So I've taken care of her now for 12 years. She's now graduated from college and is about to get married. But anyhow, more prominent blue bumps, and she was born with this. The parents said that when she was at Children's Hospital, she had this blue changes to her shoulder girdle, and nobody really knew what was going on, and nobody could figure this out. She was a straight A student, but now she's not such a straight A student, and she's not a lot of fun, and she's got these blue bumps now down her arm that she didn't used to have, and she's complaining that they hurt. And clinically, these were hard and tender, and this was quite clearly, even though it doesn't have the red streaking, clinically an SVT. And so I told them I thought that she was clotting and that we needed to get imaging. So we did that, and we also worked her up with an MRI. And here you could see all of these blue lakes and shadows. Here you can see all of the little pools underneath the skin. She also had the imaging, and you could see that she had acute SVT. And she actually, the MRI was taken at a different time, but she actually had a lot of clots in her shoulder girdle. She was hurting, and what had happened is she had hit menarche, and this is a young woman with Klippel-Trenaunay. Now, she did have some limb discrepancy that was mild, and she also had some edema, and she was not happy, and her family was not happy. We know that about 22-25% of the patients are hypercoagulable that have this process, and she was one of them. And when her hormones kicked at menarche, she started thrombosing, and she was very unhappy and in pain. Her grades dropped, her personality changed. And her father, who was a giant person, I thought was going to beat me up when I told him she was going to have to stay on lifelong anticoagulation. But he was able to give her the Lovenox shots when we started her and converted her. So she was interesting, and we needed to get her in compression. Now, we all know that teenagers love tattoos these days. And so I looked at her and I said, I think you maybe wanted a tattoo, huh? And, I get this head down, no eye contact business. And she just shakes her head. Your dad doesn't want you to have a tattoo, does he? No. Okay. So I made a deal with the patient and her father that maybe if she got her grades back up, we could think about getting tattoo sleeves for her. And these are some images just of the sleeves that are available. There's a gauntlet with this, but that she ended up getting back on the honor roll, got all straight A's, and I think she has every diva sleeve made, and became much more compliant. Pain went away. She came back to being her old self. For those of you that don't know Klippel-Trenaunay, it's a triad of varicose veins and malformations that can be arteriovenous or lymphatic. There's limb hypertrophy, bone and soft tissue overgrowth. And so she had all of those changes, but has gone on to graduate from college and became a very fun patient to see because she became like one of my own children. So again, they do make sleeves that are like tattoos for the legs as well. And again, with lymphedema, you want to make sure that you have the toes in and not the toes out. So just a point, but you can try to get buy-in because they don't have to look like old lady compression garments. You guys, thoughts from the committee and everybody? Any other thoughts?
Well, I think it's extremely important because one of the motivation for the patient not to follow the compression is that for the young ladies especially is to have this terribly looking garment, and that's the cause, not to wear them.
Well, she was really happy because not only did she get to wear these new cool sleeves, she got to hide the blue bumps, so she didn't have to explain to everybody why she had the blue bumps on her arm. And so she became very compliant, and it was just really fun to take care of. So again, super important that you get patient and family buy-in for some of this stuff.
Yeah, I would, again, congratulate you on a beautiful presentation. And again, for our other physicians and students listening and patients as well, with the Klippel-Trenaunay, one of the other pathognomonic physical exam signs would be port wine stain birthmark, which is frequently observed and can be quite extensive. And in treating the patients,
She's got this here.
yeah, in treating these patients, one of the things that one needs to be extremely careful about, in fact, about a year or so ago, I had a woman from Israel who had been seen by 3 other vascular surgeons and was told nothing could be done for her upper extremity. And actually, Peter Gloviczki and I discussed her case, and I treated her very successfully here in the office in an ambulatory setting under local anesthesia with several sessions of microphlebectomy. And one of the traps that you need to be very cautious of is the Klippel-Trenaunay Weber syndrome, where you may have micro AV fistula associated with this. And in that case, through ultrasonography in the office, very careful ultrasonography in the office, and an MRA, we were able to demonstrate those fistulae. And by the way, using a stethoscope was also valuable in hearing bruits, believe it or not. So the stethoscope is not yet, I think, relegated to the historical medical museum. It still has some function. And but the reason that's so important is because I had great temptation to do ultrasound guided foam sclerotherapy in that patient in several areas, which could have proven to be quite disastrous if I had injected through AV fistulas into the arterial side of the circulation and wound up with necrosis in that young woman's arm. So just a few caveats to this clinical complex, but beautiful, beautiful presentation. And anybody wants to comment on what I said, please do.
I've had the privilege of taking care of several of these, some of whom have had their malformations in their spinal canal. Some of them have had them around their kidney and in their pelvis. They change with pregnancy. So a word of caution, especially about this group of patients, is that when you're dealing with them, you have to be aware that they're not going to remain stable throughout the course of their life cycle. And so if you're considering pregnancy and delivery methods, you want to make sure that you have imaged the spine and the lumbar plexus and the pelvis, because one of our young ladies ended up having to be sectioned. Another one actually lost triplets because she had in vitro fertilization, and even though we asked them only to implant one, at most two embryos, they implanted several, and there were 3 that took. And at 6 months, all 3 of the babies were lost. She was bleeding from her kidney and had significant genital urinary involvement. And it was very hard for everybody because she was so attached to these babies that they were delivered and stayed with her in the neonatal unit for several days until we absolutely had to force her to separate from them. And it was hard to watch, and it was sad to be involved in. So a very big word of caution about any of these women who have central body involvement in this. And a lot of them will have it all the way, arms and legs and up and down. One young woman specifically had an arm, leg, kidney all the way up and down. And she did not stay stable during her pregnancies. And we had a lot of changes and concerns about whether we had done the right thing, was even saying that she could go through with the pregnancy. But in the end, we ended up with 2 healthy children through 2 separate pregnancies with C-sections, and she did fine. She's very happy. But again, this group of patients is not going to stay the same throughout their life cycle. And these lesions change with menarche, they change with pregnancy, and they'll change again with menopause.
Amazing. And the other thing I would add is that for those watching, very commonly affects the lower extremity. In my personal experience, I don't know if the data would bear that out, but lower extremity is probably more common than upper extremity. And as Dr. Lohr pointed out earlier in today's program, many of these people where I've made the diagnosis of KTS, they're in their 40s and 50s, and it's the first time in their life they've ever heard about Klippel-Trenaunay, which they think that I'm quite brilliant, but I can assure you that's not the case.
So any other discussions on Klippel-Trenaunay?
So the other point also is to be extremely careful at the lower extremity level, because sometimes they have this horrible the huge varicose veins, and of course it's disgraceful, and of course some of them want to get rid of them. And the issue is that very often they may have the malformation related to the deep system. And if a physician is not aware of this, you may operate and induce a really big informative for the patient, because if the deep system is not competent, and this was the main way of the flow out of the leg, then of course that may finish very badly.
Any other discussion, Dr. Iker?
No, this was wonderful presentation. I had few patients with clipal tendonitis. Unfortunately, one gentleman, young man, came from India. Somebody told him in the United States he can get cured. And unfortunately, he had discrepancy of different sizes of toes and different shapes. Also the fingers, and he had port wine stains all over his body, and one leg was grossly involved with lymphedema as well, and more so than the other. And so it was sad for him to see that we do not have a magic pill to cure him completely. But compression is the key, and you demonstrated beautiful compression. So that's complimentary. And if the patient is compliant, well, then they are ahead of the game.
Dr. Melin?
Is there any data on using micronized purified flavonoid fractions in clipal tendonitis syndrome, given both the venous and the lymphatic components, at least for potentially symptom management?
Not that I'm aware of, Monika.
No, there's no data. Logically, it could work, and I don't see any possible harm with that treatment, because it's really very safe, and working on lymphatics and working on veins. So why not? But there's no study.
And the significant anti-inflammatory component, if we're looking at
sure.
the thrombotic components, and then the inflammation quenching components, it'd be a wonderful study.
It could be a wonderful study, that's for sure.
Certainly, I've used it in all of my KTS patients. You have decreased capillary permeability, increased lymphatic flow, et cetera. And so I agree. I don't know of any particular studies being done, but logically, it makes very, very good sense, I think.
Well, John, if you have an N of 3, you might have the world's biggest experience to write up.
Yes.
My N is definitely, I hate to admit it's more than 3, but that was the one other thing I would point out. To Monika's point, I agree with Monika's point completely, that you have to be extremely cautious in treating these patients. I have treated them, and that's the other side of the coin. If the patient is worked up properly and the deep system is evaluated properly, this element of arteriovenous fistula is evaluated properly, et cetera, I've seen other patients who have been neglected by vascular surgeons who are just sort of terrified to touch them or intervene. And I've been able to help a lot of those patients as well. To be very candid, early on, going back nearly 20 years, a patient of mine named Michael, who's still he has my cell phone number, he calls me all the time, is one of the first KTS patients I intervened on, very hesitantly at first and very cautiously at first. But I did so because he was a clinical stage 6 with a large open ulcer. And so I didn't feel that I had much chance, but I did every test you could possibly imagine before doing the first procedure, because I was so terrified about making him worse. But indeed, we did make him better. And he's been managed over these many years with procedures as he's threatened to reopen that ulcer. So it's been a combination, again, of endovenous laser, microflebectomy, and ultrasound-guided sclerotherapy when needed. But he does have a competent deep system, and most importantly, a non-obstructed deep system. I think that you can get away with treating the superficial system in many of these patients, even if they have venous insufficiency in the deep system, as long as they don't have an obstruction. And certainly one needs to be certain that the profunda is open.
Exactly.
I think it's really critical to stress a couple things that you stated there, and that is that you need to have a complete workup of both the arterial and venous side of this before you consider any intervention. And the other thing that you stated very clearly is that you did small interventions at a time and you didn't try to do one big fix it all at once, because if you do too much, you will definitely get in trouble with these patients.
Agreed. I couldn't agree with you more. And in fact, when you go back to the arm case of the woman, it's actually kind of a humorous story in a sense. She was so happy and so thrilled that she came back about 2 years later and wanted more done. And I consulted again with Peter Gloviczki, who was quite, thrilled with, what we had accomplished the first time around. And he said, you took this woman who had a very sick arm and you gave her a good arm. And now she's looking for a perfect arm. And you can tell her that, I said that she's never going to have a perfect arm. And I did relay that message. That being said, we did some more work very, very cautiously and in stages, and touch wood, everything has worked out well. But I think you have to be, discretion is the better part of valor in these cases, and to stage it and see how the patient responds physiologically and anatomically and symptomatically is beyond wise. I think it should be seen as mandatory, quite frankly.
Any other discussion points from anybody?
Well, I think also, Joann, that talking about the MPFF, I'm not sure if you ever had the opportunity to treat your patient with this supplement.
It seems to help. I don't have good data on it, but symptomatically with just an isolated couple of patients, they seem to have less pain and be significantly more active.
Well, anytime if you want to have more information, I can send you about it.
It sounds like a stimulus to somehow get this in peer-reviewed literature, because clearly there is potential to help with patient management. I mean, clearly, and I think you've done such a great job of pointing out how this is an interdisciplinary collaborative management that requires really thoughtful input to get the best outcomes.
And I think with some of the quality of life markers and things that are available, Monika, I think you could probably design a study pretty well to show that it does help.
Mm-hmm.
I would just point out one more thing that Mark was touching on outside of this idea of MPFF. Another thing for all physicians, but especially younger physicians, this is especially important, I think, in the world of venous and lymphatic medicine, which has more and more over the years moved to the outpatient setting, to the ambulatory setting, the office setting, et cetera. And those of us who practice in this setting often become somewhat isolated from our colleagues and the hospital environment and so forth. So when I was doing open heart surgery, the whole environmental milieu that you're working within is more collaborative, interdisciplinary, et cetera. When you get out into the community in an office-based clinical situation, you can find yourself getting more and more isolated. And I want to reiterate what Dr. Lohr and Dr. Melin have said. Don't fall into that trap. Feel comfortable reaching out to your colleagues, get other opinions, get other viewpoints, get more tests before, especially with surgical intervention, you can't undo any operation. You can always put it off and fight another day. It's not a ruptured aortic aneurysm, and it's not a ruptured appendix. In these kinds of challenging clinical scenarios, if you're not absolutely certain what you're dealing with, what you're looking at, what the treatment should be, it is not a failure, despite what many of us learned in surgical residency. It is not a failure to look for another opinion, experience, expertise, another point of view, because again, rule number one in the Hippocratic Oath is do no harm. And as I think we've all pointed out, in challenging clinical cases like this, it is not difficult to harm someone if you're not really, really cautious and very knowledgeable in what you're doing. So don't be in a rush to act. Make sure you have an excellent plan and the boat loaded with lots of experts and lots of studies and lots of documentation, because it doesn't take much for this sort of thing to go in the wrong direction. And no one ever wants to see that in their practice, and nobody wants to see that for their patient, ever.
At VitaSupport MD, we believe in creating the best bioflavonoid-based supplements to support your vitality. Bioflavonoids are found in abundance in nature and support excellent health and wellness. The demands and stresses being put on our bodies in these challenging times are unlike any we have seen before. Support your body with the flavonoids it needs to fight inflammation and oxidation. Unlike other products in the marketplace, VitaSupport MD dietary supplements use micronized flavonoids for optimal absorption and effectiveness. Micronization is an advanced process which creates an ultra-fine powder easily absorbed by the body. At VitaSupport MD, we are passionate about making your good health our life's work.
Yeah, this is a case where less is usually more. And everybody needs to understand this is going to be a chronic process. So
And
go ahead,
yeah,
sorry.
Last thing, in the patient whose arm we did operate on, or I did operate on, the only reason that I really operated on her arm, although it had become quite disfigured with massive varicosities, and it was she of course had limb hypertrophy, but she developed ultimately intractable pain in the hand. And Emily may want to comment on this too, to the extent that she could no longer tolerate upper extremity compression using a gauntlet, et cetera, which she had worn for years. But it got to the point where the gauntlet and the sleeve made things worse, and she really had a major pain problem, a major pain issue. And just like the first patient who had the ulcer in the lower extremity, it was this intractable pain that finally forced my hand to do something.
John, you just pointed out something very important. When we have lymphedema, and especially in the hand, fingers, and the wrist, one has to be very careful what kind of a garment, compression garment, you recommend, because frequently I see very beautiful garments, and what they are very narrow at the wrist, and then allowing the backflow to the hand and fingers, and then of course it induces the pain. And so in that sense, one has to either do bandaging to reduce the swelling and then fit the patient with appropriate garment, and not allowing the segmental compression or tourniquet effect at the wrist part or the hand. So that will be one point. And another point, I've seen a lot of patients with primary lymphedema or different types of lymphedema, and it is incredible to see the ill-fitted garments. And I think the ill-fitted garments are more frequent than reflex sympathetic dystrophy. So one has to evaluate what the garment looks like, how does it feel, and do you get swelling into the hand, do you get swelling into the foot and toes? And a lot of the not custom-made garments, they are created especially for low extremity in such a way that there is a narrowing at the ankle part, distal ankle, and then it flares up into the foot and toes. And so at the end of the day, the patients end up with more swelling in the foot and toes. And it's only because of the ill-fitted garment. So since I have a personal experience, I can tell you which garments are the best for which patient. And then we go according to that. But again, compliance is the key.
Well, one of the things about the gauntlets is that some of the garments are made with the seams in the wrong place. And if they have any seams anywhere, they seem to be a focus of great pain and discomfort because they're stiffer than the rest of the garment and they become problematic. So a lot of patients need to try different kinds of garments or have custom garments made or just wrap. And so that's one issue. The other issue, if you're looking at standard compression garments off the shelf, in the lower extremities, the calf circumference can vary up to 6 inches in the extra large, depending on which brand you're using and how they're made. And I have a talk where I put up all of the Nike and Adidas slides and Pumas and all of those things. And I then put up all of the different compression brands. And it's kind of like the same. Everybody has a tennis shoe they like better than another one, but certain things fit certain people well. In the Midwest, we had a lot of voluptuous patients with rather large calves. And so the calf circumference ended up being a big problem. And the ankle was frequently a tourniquet site. So again, I can't agree with you more, Dr. Iker, that they have to be fitted properly. A poorly fitted garment is much harder to overcome when you see patients that have been mismanaged than almost anything else. I'm going to briefly show you a couple of other things that, sort of like this puppy of mine. He's really good when he's sitting and staying, but if you don't like him, he could get in your face. And that's kind of what advanced disease does. It just really can take over and be rather ugly. And again, this goes to your point of phlebo lymphedema in a patient. But the next patient I'm going to show you is sadly a handicapped young lady who was not cared for and was shuffled from a couple of different homes. You can see she's got some changes here in over riding her shoe, but she hasn't had a shoe on this foot in some time. Very sad case. And you can see all of the changes of end stage, poorly managed lymphedema, phlebo lymphedema, because she does have some venous component. But she's got all the tissue overgrowth and matting, secondary fungal infection. And she came in because of pain and odor more than anything is why they brought her in. Unfortunately, I can't tell you that I had a happy ending because she was transferred to a different sheltered home and I never got to follow her more than a couple of weeks. But I always worried that she was going to end up with an amputation. We were able to get some of this debris down, but this is basically untreated disease. And you can see here, she's got a lot of the thickening of the callus and the leathery skin, the papillomatosis and all the overgrowth. She did have normal arterial circulation, I can tell you that. But this is a very sad, very advanced case. So again, controlling infection, controlling the fungus, getting skin care started, getting her in some form of compression. This is where we use the Velcro wraps to start because she could not tolerate much compression initially. She could not tolerate any decompressive therapy. And she was quite a challenge. I always wondered what happened to her, but she was one of my people that I lost to follow up, unfortunately, because I would have liked to seen her if we could have done anything more to help her. Thoughts from the panel?
It really brings up that thought about what one of the major causes worldwide is for lymphedema is filarial disease. Because if you're on the continent of Africa and elsewhere where it's endemic, this is not an uncommon sight to see. And it's really, so it's very educational to see this. And I'm so glad you're showing us this particular patient.
So, again, the rule out of central venous obstruction was done and we just didn't have a lot to offer her. It was very frustrating to see that she had been allowed to progress this way. But this is another patient who's been allowed to progress and is basically in the same predicament of untreated advanced disease. Now, this patient did have a iliac vein obstruction and got some relief with stenting, but there's just not a lot to offer. So my last segment was just a little brief thing about the difference between lymphedema and lipedema. And here you can see the classic lipedema patient with the sparing of the feet, the tourniqueting of the ankles, and the maldistribution of fat. So you can see the little telangiectatic mats, and she had a lot of bruising. I just wanted to bring these cases to you so you can have an idea, especially for people that don't see or haven't seen a lot of these people. Another lipedema patient with some venous changes as well. And then this is one of my young friends who has severe lipedema. And again, that's an abnormality in the fat deposits and lipid metabolism, really not just obesity. And remember, obesity is everywhere, not isolated to the lower extremities. And for the most part, lipedema affects the lower extremities more than anywhere else. It begins with the upper thighs and the legs, and sparing of the feet, unlike the lymphedema pictures we started with. And so, I'll open it up for discussion. And again, both lymphedema and lipedema are more predominant in women. And we just need to be able to help and recognize what's going on and make the correct recommendations. And as we pointed out, do no harm to these people. Comments, Dr. Melin.
So I'm so glad you brought up the lipedema component. Steve Dean, who's at the Ohio State, taught me probably 6 years ago about the critical nature of starting these patients on MPFF, and micronized purified flavonoid fractions for our lipedemic patients, especially in the wound clinic, has made a world of difference. I do know there is unpublished data that will hopefully show up at AVLS this fall, showing the benefits of MPFF in lipedemic patients. So I think there needs to be further study on this particular subject. But again, back to that component of with the inflammation component, I think there's great benefit. And we see most of these patients, that pain component in lipedema really gets significantly better within about 4 to 8 weeks of starting dosing.
My patients in Cincinnati were very upset with me when I left, but Dr. Dean agreed graciously to see everybody from Cincinnati and Columbus for me. So he's taken over a lot of these patients for me.
Yeah, he's such a kind and gracious gentleman. He does a wonderful job of both educating as well as taking care of patients.
No question. Any other comments? Dr. Iker,
This
Dr.
was
Gloviczki?
beautiful, beautiful presentation. And Mark, we have about 26 patients, lipedema patients, and what I am doing in summary is checking the pain level before and after, quality of life, and mobility. And quite a few patients, lipedema patients, said immediately after taking a lymphatic formula, they felt a relief of the pain. And of course, it maintains, it doesn't fluctuate back and forth. And so we will have the summary. And well, I'll talk with you more about the statement that you sent to me, wonderful. But then if we can focus only on those three, because I am doing just the questionnaire for time being. And phase 2 can be the other studies that you mentioned.
Vein Formula 1000 and Lymphatic Formula 1000 from VitaSupport MD are backed by science and sold in doctors' offices. If you're a physician who may be interested in prescribing or selling these excellent nutraceuticals, please call 862-246-7877 to speak to a representative today.
So what about the other treatment for the lipedema cases? What would you recommend it, especially for the young patients?
What I'm doing, Monika, whenever I see a new consultation, I do ultrasound study. The only thing is, and of course, I'm looking at the behavior of the skin and skin changes, subcutaneous space, and what's the expansion at, and I usually measure at the lateral thigh, distal medial, medial calf, and medial ankle. And I do it in about 10 sessions, 12 sessions, and then I repeat the ultrasound. And all these patients are pretty much on the lymphatic formula. The only thing is we are also combining treatment modalities, manual lymph drainage, compression pump treatment, therapeutic exercises, and of course, patients' compliance and compression. So along with the lymphatic formula. So at this point, it's hard to separate which one is just because of the lymphatic formula, because it's a combination factor. So
well, the most important that you see the effect of this complex therapy on patients' well-being. You know, I mean, certainly each part plays a role, but I think that altogether the most important is the final result and the satisfaction of patient.
right.
There was that data that came out of Paula Donahue and Rachel Kazani's group in Vanderbilt last year that showed, so they have the ability to do sodium 23 MRI scanning, specifically at sodium within the lymphatics, and they found that with MLD as well as complete decongestive physiotherapy, so exercise, compression. Now they did not use MPFF, but it was amazing the reduction in the dermal sodium levels, and sodium in the skin is incredibly inflammatory, just like iron overload within the skin with our hemosiderin deposition patients is so inflammatory. So it leads us to, we know that we have a very over sodiumed nation, and asking the simple thing about salting your food, trying to ascertain how much salt they're taking a day, it's certainly one thing I think we can do to help decrease inflammation in our patients with lipedema, as well as with lymphedema, as well as with venous disease.
Yeah, that was fantastic study. And
I would certainly agree that the approach to these complex problems, like so many problems in medicine, is going to be multifactorial, multimodality, and it's the synergistic effect between numerous efforts that are going to have the most promising long-term results. And it's an interesting compendium of disease processes, as we all know. It's frustrating in many ways, especially advanced stages of lipedema, lymphedema, phlebolymphedema, et cetera. One of the conversations that I have with my patients frequently, for example, if they have lipodermatosclerosis, and we find that they have significant truncal venous insufficiency that's going to be ablated, treated, et cetera. Of course, a very logical question would be, like, doctor, is this going to get better? Are you going to be able to reverse this? Is this going to go away? And typically what I will tell them is that I certainly can't guarantee that. In some cases, it does resolve to some degree or another. But most importantly, our goal is to prevent the lipodermatosclerosis, stage 4B, to become a stage 6. That's the big goal, and that's the first and most important goal. Anything we get on top of that is gravy. So we're going to do compression, we're going to do elevation, we're going to do exercise, we're going to talk about dietary changes, we're going to talk about weight loss, we're going to talk about endovenous ablation, ultrasound guided foam sclerotherapy, MPFF, dietary supplementation, compression, graduated compression, et cetera, et cetera, et cetera. A dozen things in combination, not knowing in that patient which one of those things is going to have the greatest impact or lesser impact. We have more and less evidence for the various things, and we have more or less compliance for the various things. Of course, we all know that of all, the patient hates to wear the graduated compression garment, number one. The point that I want to make is that in some of these elements of treatment, it isn't always essential that the patient sees or feels some dramatic improvement as evidence that the treatment is effective, because we're dealing with a chronic progressive disease state. So just as I don't feel better when I brush my teeth with toothpaste that contains fluoride, it's not that I had a toothache and now the fluoride has alleviated my toothache. We have evidence to show that fluoride in toothpaste over the course of a lifetime is protective of enamel and less likely to develop tooth decay and dental caries and so on and so forth. So I think part of the barometer for things like compression stockings, interventions, and dietary supplementation with MPFF, the bar has been set probably too high in some cases because people are looking for, and in research and in studies, when you're looking at quantitative objective measures to try to show effectiveness, it makes sense. But there is also an element within me that knows that if I put an obese patient on a walking regimen and he doesn't lose 2 pounds, but he starts walking 2 miles a day, he's healthier than when he was sedentary. There's obviously a lot of good data in the cardiac literature to support that as well. But my point is that with these interventions, we're not always going to see objective or subjective improvement. But that's not proof that we shouldn't be taking a full multimodality approach whenever we have a cooperative patient. And that always makes our job a little bit easier.
One of the other things that I would add to that, and this is a little bit off the subject, is everybody needs to remember the anti-inflammatory side effects of heparin and Lovenox compared to DOACs. And so when you're treating people, the quickest way to turn down the inflammation of a clot or a thrombotic event is to put them on some form of a heparin compound. And yeah, they don't like to take shots, but it's amazing how quickly they will feel better symptomatically. And so, you know, the move to DOACs is always, I think, should be taken with a little word of caution.
That is such a critical point because it has to do with quenching endothelial cell inflammation. And I'm so glad you raised that point because especially so many young physicians coming up, their first go-to is the DOACs because historically they haven't had the experience to see the clinical change with a heparin drip and how therapeutic that can be. People literally start feeling better within 12 hours on a heparin drip. So thank you for bringing that point up. That was really critical.
Well, thank you. But the other point to make with that is that, you know, when you're trying to select the initial anticoagulation agent, you have to have a baseline PTT, because if the baseline PTT is elevated, it's a tip-off that you may have an unrecognized, undiagnosed inhibitor, and those papers should not be placed on a DOAC until you have the workup completed, or you're setting yourself up for a potential big problem with a DOAC failure.
And I'm going to say it for Mark because he gets a little shy about this sometimes. And that anti-inflammatory effect is key in protecting the glycocalyx.
Glycocalyx.
So with that, it's not a punchline, Mark. I just want you to know. It's just a closing statement. With that, I would like to thank our guest so much for...
Go ahead. Sorry.
Oh, go ahead, Joann. You go ahead.
I just wanted to say thank you to everybody for including me, and that your flowers will be blooming in California again soon. And it's an exciting time in the area of venous and lymphatic disease, because now we have some knowledge, we have a language we can talk, and we are blooming, and it's a huge opportunity to offer great improvement for our patients going forward. And there's ample opportunity for lots of research in this area. So for all young investigators and people on this call, please think about some of the exciting things, because we still have so much more to learn and so much untouched knowledge that we need to gain. And again, thank you for the privilege of sharing some of my friends over the years with all of you.
Beautifully said. And I love the way you refer to your patients as your friends. I have not heard that before in all these years. So that's a beautiful sentiment. And I would just echo your remark by saying people in the world of vascular surgery and vascular medicine in general need to remember that there's not only one side to the circulation, and there are definitely at least two. And I think Dr. Gloviczki and Dr. Iker and Dr. Melin would insist that there are three elements in the circulation, and that they all need to be respected, and they all need to be regarded as important, and they all need to be treated, and none should be neglected. We saw some dramatic slides from Dr. Lohr today of what a neglected limb looks like. And it's quite, even for those of us who have been in medicine for decades, images like that are still quite off-putting and disturbing. And for that reason, they're powerful and they motivate us to do the best job that we can in early detection, early diagnosis, early treatment, early intervention remains the key to avoiding those kinds of very disturbing outcomes for people who are otherwise very good people. And so thank you for sharing those strong images. And I will ask Dr. Iker for her closing remarks, if she would be so kind.
Thank you, Dr. Lohr, and thank you, the team. This was fantastic presentation. I really enjoyed the slides, most of them, and hopefully next time I will show you blooming flowers from California.
Thank you so much. Dr. Melin?
Well, Dr. Lohr, I would just say you have a beautiful yard, a gorgeous dog, just a wonderful breed, and a really distinct professional way of education. So I just thank you for what you've done during your career. We've all benefited from everything you've done to uplift us in the society. And Monika, thank you for inviting her to join us today. It was wonderful.
And with that, Monika, why don't you take the privilege of giving your final remarks and saying thank you to our esteemed guest.
Thank you, Joann. I feel privileged because I count you among my very close friends. And I just wanted to say one sentence about how important the American Venous Forum is for you and for me in regard to our professional and private life, because truly, the relationship that we build, like relationship that I have with you and with our other friends, are priceless. This is absolutely wonderful adventure for me. And thank you for sharing all this experience with us. I hope that this is not the last time that you are visiting LymphCast, because we only touched the surface of what we can discuss together. And you see how fast the time went by. So thank you again. Thank you, team, for being all together with Joann. And well, thank you for our listener. I hope that we bring something to the listener who wants to know a little bit more about lymphedema, lipedema, and venous disease.
I'm sorry, Joann, we'll give you the last word.
Well, I just again want to say thank you to the team and to Monika specifically for the invitation and the privilege of sharing some of these wonderful people with you all. And it's a huge opportunity for our young friends and people on the call to make positive impact in your professional careers as you go forward. The beauty of societies and meetings is networking and establishing friends. Monika, I could not find the picture of you and I and Peter in the pink Cadillac in Monaco, but I was going to include that. So again, it's a privilege to grow old with all of you and to watch all the young people. It's exciting to see all the changes coming forward. So if I can be of help, you please feel free to contact me. I think my email is just about everywhere, and I can give you a cell phone contact if you need it. So if I can help anybody going forward with any cases or anything, please feel free to contact me.
That's very gracious and very generous. I thank you all for your participation today. I think it was another very successful program, and I look forward to seeing you all again soon on our next episode, episode 23 of the LymphCast podcast. Thank you, everyone.